All right, guys, we'll get started. So I have the pleasure this morning of introducing Shifteh Vahidi, who is a fourth-year AP-CP resident here at the university. Shifteh finished her medical school at the University of Tehran, Tehran University, of Medical Sciences. She finished a pathology residency in Iran as well as a dermatopathology fellowship. She was practicing pathology there before she came to our program, where she's wrapping up her training. And she will talk today about malignant mesothelioma. So, thanks, Shifteh.
Good morning, everyone, and thanks to Miro for introducing me. The subject that I'm going to talk today is diffuse malignant mesothelioma. And this was a CAP-PIP case that I worked on during my rotation in Abbott Northwestern Hospital. And today I'm trying to cover the most practical points of this entity in less than 1 hour. I have no disclosures. My objective is to talk about the most recent WHO classification and including different subtypes and also the histologic patterns, and discuss the immunohistochemical features that helps to make this diagnosis, including the differentials, and also to introduce the new molecular markers that have been extensively studied during year 2015 for differentiating between benign versus malignant mesothelial proliferation. Malignant mesothelioma is a rare aggressive neoplasm which originates from the mesothelial cell linings of the serosal cavity. Usually it's a very challenging diagnosis because some mesotheliomas can mimic benign reactive processes because they look very bland. And on the other hand, some benign reactive processes can have marked cytologic atypia, so they can mimic malignancies. On the other hand, malignant mesothelioma has multiple histologic patterns that can mimic various kinds of metastatic adenocarcinomas, malignant melanomas, sarcomas, even benign processes. So usually the diagnosis is not very easy, especially the specimens that we give are small and is from needle biopsies. On the other hand, usually this diagnosis brings with it its poor prognosis. Usually most of the patients do not survive more than 1 year after the diagnosis. The legal aspects of this diagnosis adds to its complexity because this is one of the most significant occupational exposure disorders related to asbestos exposure. It's recommended that consultation with a pulmonary pathologist is required almost in every case of malignant mesothelioma except for the very straightforward one. In spite of all of these facts, fortunately it is not a very common diagnosis. Pleural cavity is the most common site for origin for malignant mesothelioma. About 65 to 70% of the cases arise from pleural cavity. About 30% arises from peritoneal cavity. And tunica albuginea of the testes and pericardium represent only about 1 to 2%. From the epidemiologic standpoint, mesothelioma is not a common malignancy. The exact prevalence of the disease is not known, but it has been estimated that it represents about 1% of all cancers. The majority of the cases are diagnosed in patients more than 60 years old, and it is more common in male, and this may reflect the differences in occupational exposures, as men are more involved in jobs that are associated with asbestos exposure. The incidence rate of mesothelioma has been increasing in different parts of the world, and this is related to asbestos exposure and usage in different countries around the world. However, the annual incidence in United States it decreased, and this is related to the better control and asbestos restrictions in United States. However, still the population of United States are in risk for developing mesothelioma, and this is related to the long latency period between exposure and carcinogenesis that sometimes it's estimated to be about 20 to 50 years. Each year, about 3,000 cases of malignant mesothelioma are diagnosed in the United States with an average incidence rate of 1.05. These figures is from, this diagram is from Seer Cancer Registry data and shows the incidence rate of mesothelioma in United States. As shown in the diagram, the incidence rate of mesothelioma increased until 1990. Then for several years it was almost level, and since 2005 the incidence rate decreased in men. In women, there was slight increase in incidence rate of mesothelioma until year 1985. However, it was little change since 1985 in the incidence rate of mesothelioma in women. Also, this slide shows the incidence rate of mesothelioma in United States. As I mentioned before, about 3,000 cases is diagnosed in the United States, and states that have high incidence rate of mesothelioma, including Washington, D.C., West Virginia, New Jersey, are states that are more involved in asbestos-related industries, including shipyard buildings or mining, asbestos minings. This figure shows the incidence rate of mesothelioma in different countries in the world, with United Kingdom and Australia having the highest incidence of mesothelioma. These are the countries that are surrounded with water, and they are involved in shipyard manufacturing. Asbestos exposure is the most significant risk factor for developing mesothelioma, and this association is higher in plural compared with peritoneal mesothelioma. About 87% of the cases of mesothelioma arise from pleural cavity. However, only about 33% of the patients with peritoneal mesothelioma have a previous history of asbestos exposure. Although this association is well established, however, only about 5% of the patients who are heavily exposed to asbestos develop malignant mesothelioma, and this is related, in fact, to genetic predisposition, and suggested some genes that are involved in pathogenesis of mesothelioma, including BAP1, which I'm going to talk about it later, and recently is one of the new molecular markers for diagnosis of mesothelioma. Asbestos is an environmental carcinogen. It is involved in carcinogenicity of the lung and also mesothelium. It is a family of natural minerals which are classified into two main groups, including serpentines and amphiboles. Serpentines have short, curly fibers. Amphiboles have straight and long fibers. Both of them are carcinogen. However, our carcinogenicity of amphiboles is about 2-3 times than serpentines. But the main usage of asbestos, about 95%, includes the serpentines. Asbestos is used in different industries, including in house manufacturing, for building roofs, walls, buildings, and also for insulation of the pipes, and also in shipyard buildings, car brakes, and many other different industries. The exact pathogenicity of how asbestos results in carcinogenicity is not known. However, it has been suggested that after inhalation of asbestos fibers, they penetrate into the lung tissue and mesothelial cells. Interaction of the asbestos fibers with macrophages and mesothelial cells results in secretion of various types of cytokine and reactive oxygen species, and these result in repeated cycles of tissue damage and repair and inflammation, and this leads to carcinogenicity. It has been suggested that reactive oxygen species can result in direct DNA damage, and also after penetration of the asbestos fiber inside the mesothelial cells, they can interact directly with the spindle, mitotic spindles, and also result in structural abnormalities in chromosomes and result in carcinogenicity. Steve Mcqueen is one of the most famous victims of mesothelioma, who died in 1980 because of mesothelioma. Before becoming an actor, he worked in United States Marine, where he required to remove the asbestos laggings from the pipes, so he dies of asbestos at age 50. After this introduction, I'm going to talk about the diagnosis of mesothelioma, which is the main subject of my talk. The diagnosis of mesothelioma is based on the clinical, radiologic, also thoracoscopic, and adequate biopsy, pathologic examination. Usually the clinical manifestations are non-specific. The patients are diagnosed in late stage. Usually the symptoms are non-specific, and there is a delay between presentation and diagnosis with an average time of about 4 months. On X-rays, mesothelioma usually present as unilateral pleural effusion or either as a solid pleural mass. More commonly, it presents as diffuse or focal mesothelial thickening. Any concerning lesion on CT scan can be followed on, any concerning lesion on X-ray is followed in CT scan. Again, in CT scan, it can appear as calcified pleural plaques or unilateral pleural effusions. Also, it can present as solid pleural masses. Sometimes they can present at interlobal fissure thickening or diffuse thickening of the pleura with encasing of the lung. And sometimes CT scan also provide additional information regarding the extension of the tumor, especially in the chest wall, involvement of the intercostal muscles and also ribs, and also extension of the tumor in the mediastinal structures. And CT scan is used for, in fact, staging of the mesothelioma. PET-CT provides additional information about the extra extension of the extrathoracic extension of the tumor, and also localize the area of dye intake, uptake, and it's the guide for further biopsies. Early mesotheliomas usually present with small nodules distributed on the parietal peritoneum, less commonly on the visceral pleura or peritoneum. However, with progression of mesothelioma, the nodules get together and encase the lung and result in diffuse peritoneal thickening. However, the definitive diagnosis of mesothelioma requires tissue biopsy. Usually the tissue biopsy is required to show the neoplastic invasion, which is a morphologic diagnosis, and also to show the mesothelial phenotype of the neoplasm, which is confirmed by immunohistochemical stains. Less commonly, the diagnosis is made on cytology. However, use of cytology in diagnosis of mesothelioma is controversial, and some institutions are comfortable for calling mesothelioma on cytology specimens, and some institutions, they are not willing to make this diagnosis on cytology because of the inability to evaluate invasion. However, recent studies have shown that cytology, besides ancillary studies, can be helpful for differentiation and diagnosis of mesothelioma. Usually, differentiation of reactive mesothelial proliferation from malignant mesothelioma sometimes can be very challenging. Sometimes the mesothelial cells can show significant cytologic atypia, and diagnosis, especially on needle biopsies, is impossible. And sometimes even experts in the field have disagreement for this differentiation. This diagram shows a thickened pleural tissue with extrapleural fat. Mesothelial cell proliferations that are confined to the surface, these may be benign or malignant. Proliferations that extend from the surface to the fat, these are usually malignant, and proliferations that invade into the fat, these are always malignant, and mesothelial proliferations that goes parallel to the surface, they represent usually repeated cycle of organization and mesothelial proliferations, and these are usually benign. This figure shows the pleural tissue with florid mesothelial hyperplasia with significant cytologic atypia, and for example on this case making a diagnosis of benign versus malignant on a needle biopsy is almost impossible, and the only diagnosis that we can make is atypical mesothelial proliferation. However, on this case, follow-up of the patient showed that this was a benign mesothelial proliferation secondary to emphysema. This section shows thickened pericardial tissue, and cytokeratin stains highlight the proliferated mesothelial cells parallel to the surface and have a linear arrangement. These are usually again represent benign organizing effusions. Sometimes mesothelial cell proliferations can have marked cytologic atypia. They can have mitotic figures. However, benign reactions usually are well demarcated, and cytokeratin stain can highlight these line of demarcation from which we cannot see any mesothelial cells going beyond this line. The definitive diagnosis of mesothelioma is based on a stromal invasion, and fat is the most frequent stroma. Cytokeratin stain usually highlights the distribution of mesothelial cells into the fat and can highlight the subtle invasions when it is not apparent on H&Es. Another form of stromal invasion is full thickness involvement of thickened pleura and proliferation of the mesothelial cells through this thickness. So usually these kind of proliferations are malignant, and this represents another form of invasion. Another variant of invasion is formation of expansile nodules. Usually maybe the mesothelial cells in these nodules may be scanned, and they may show scanned cytopologic atypia. However, formation of expansile nodules again is not indicative of benign processes, and usually this is seen in malignant mesothelioma. One of the variants of mesothelioma, Desmoplastic Mesothelioma, is a very challenging diagnosis. It is almost impossible to make this diagnosis on a needle biopsy. It looks like scar on low power. It's hypocellular with bland looking cell. However, again, cytokeratin stain can show invasion into the fat. And however, care must be taken to make sure that the spaces that we see and look like fat are real fat, because sometimes in late organizing pleuritis we can have fat-like spaces with cytokeratin positive cells between these fat-like spaces. However, these are not real fat, these are called fake fat, and in fact it's a tissue processing artifact. And the differentiation with this desmoplastic mesothelioma is based on tissue invasion into the fat. Usually mesotheliomas are more cellular, and the neoplastic cells run downward through the fat rather than parallel proliferation and linear arrangement of the neoplastic cells in reactive processes. In suspicious cases, S100 stain can differentiate between fake fat and adipose fat. Real fat is S100 positive. Based on the WHO classification of 2015, mesotheliomas are divided in tumors of the pleura are divided into three main groups, including mesothelial tumors, lymphoproliferative, and mesenchymal tumors. Today I am covering only this group, which are diffuse malignant mesotheliomas. Diffuse malignant mesotheliomas are divided into three subtypes including epithelioid mesothelioma, sarcomatoid mesothelioma, and biphasic mesotheliomas. Epithelioid mesotheliomas are the most common type. Sarcomatoid and biphasic represent about 10 to 15% of the cases. This was an article which was published on May 2013. Here, pathologists from International Mesothelioma Group were involved in this update, and they presented a very nice guideline for reporting of malignant mesotheliomas. Based on this article, the subtypes is similar to what we have in WHO classification. However, they describe multiple histologic patterns for each group, and recognition of these patterns are important because some of them can mimic metastatic adenocarcinomas or lymphomas or melanomas, for example. And also recognition of these patterns is important because it helps the pathologist to choose the appropriate immunohistochemical pattern to get to correct diagnosis. Also, these patterns have prognostic significance, and recognition of these patterns is important, and reporting them is important in our pathology report. The most common types are tubulopapillary, solid, and trabecular type. The tubulopapillary type usually composed of papillary structures with fibrovascular cores, which is lined by bland-looking cells. In the solid type, usually it composed of sheets of neoplastic cells with vesicular nuclei, prominent nucleoli, and variable decrease of mitotic activity, and presence of pleomorphism and nuclear anaplasia in more than 10% of the tumor classifies the tumor as pleomorphic. And recognition of this pattern is important because the pleomorphic type usually is associated with adverse prognosis. The survival rate is similar to sarcomatoid, and maybe in future years pleomorphic be reclassified as sarcomatoid type. Micropapillary pattern is different than papillary because usually it's composed of papillary structures without fibrovascular core, and again recognition of this pattern is important because it is associated with higher incidence of lymphatic invasions. The microcystic or adenomatoid form is characterized by presence of microcystic structures and cells with vacuolated cytoplasm. Recognition of this pattern is important because it is in the differential diagnosis with metastatic signet cell adenocarcinomas. Tubular pattern usually composed of glandular structures. It is in differential diagnosis with metastatic adenocarcinomas. The trabecular pattern with arrangement of the neoplastic cells in a trabecular pattern. Malignant mesothelioma with myxoid stroma. Usually this pattern is associated with favorable prognosis and improved survival. The deciduoid pattern is associated with adverse prognosis. Usually the cells are large, well demarcated, and have a glassy cytoplasm. This pattern, lymphohistiocytic pattern, usually is composed of these cohesive cells of neoplastic cells. This picture highlights the neoplastic cells with cytokeratin stain and have intense inflammatory background, and these are in the differential diagnosis with inflammatory processes and also malignant lymphomas. Sarcomatoid mesotheliomas are a form of aggressive neoplasm. Usually the survival is low. Is composed of spindle cells arranged in interlacing fascicles. Usually these present only in pleura. They are very rare in peritoneum, and they can have heterologous differentiation with presence of osteosarcomatous and rhabdomyosarcomatous or chondrosarcoma area. Desmoplastic mesothelioma is a variant of sarcomatoid with presence of dense fibrocollagenous tissue and bland-looking cells. And as I mentioned before, this type is very challenging. The diagnosis of this type is very challenging, especially on needle biopsies, and it's only diagnosed on resection specimen based on fat invasion. And the last group is biphasic mesotheliomas. These are composed of both components, sarcomatoid and epithelioid type, and each need to be at least 10% to be classified as biphasic. Recognition of these patterns is important from the prognostic standpoint, with epithelioid having the best prognosis with median overall survival of about 16 months. Sarcomatoid and pleomorphic are the worst prognosis, and the survival rates are almost similar with median survival life of about 4 months, and biphasic are in between and have a median survival rate of about 7 months. Also, recognition of these histologic types are important because some of them had adverse prognosis, with pleomorphic having the worst prognosis, followed by solid, micropapillary, tubulopapillary, and trabecular type. So the malignant mesothelioma is in the differential diagnosis of many kinds of metastatic adenocarcinomas and sarcomas, and this depends on the primary site of the tumor, whether it arises from pleura or pericardium, and also depends on the histologic subtypes of the tumor. For the tumors of the pleura, the most significant histologic differentials are metastatic adenocarcinomas of the lung and also metastatic adenocarcinomas from different primaries, including carcinomas of the kidney, GI, or breast, or any other primaries. The most significant differentials for peritoneal mesotheliomas are serous papillary adenocarcinomas of the ovary and serous carcinomas of the peritoneum. For sarcomatoid mesotheliomas, the most common differentials are sarcomas of the chest wall, either primary or secondary, and also sarcomatoid carcinomas. So it has been suggested that for every case of malignant mesothelioma should be confirmed by immunohistochemical stains, and for diagnosis of mesothelioma we need 2 positive and 2 negative markers. The negative markers depend on the tumor that is considered in the differential diagnosis. And the most frequent positive markers that we use includes 4 stains: calretinine, WT1, CK56, and D240. Calretinine stain is one of the most useful stains for diagnosis of mesothelioma. Attention to the pattern of staining is important in all of these stains. For calretinine, the pattern of staining is both nuclear and cytoplasmic, and it should be diffuse and strong. This is the pattern that we expect for calretinine for malignant mesotheliomas. And attention to this pattern is important because sometimes adenocarcinomas of the lung can be calretinine with presence of weak and focal staining. However, this pattern is what we expect for malignant mesothelioma. WT1 is the next stain. Usually the expression of WT1 is strong nuclear staining. Again, attention to this pattern is important because some adenocarcinomas of the lung can have cytoplasmic positivity for WT1. So attention to this pattern is important. Also, WT1 can be present in serous carcinomas of ovary or peritoneum. So whenever the differential includes serous carcinomas, WT1 is not helpful. The next stain is CK56, expressed in most of the epithelioid mesotheliomas. The problem with CK56 is sometimes it can have focal staining. So in needle biopsy, we can have false negative results for CK56. It can be expressed in squamous cell carcinomas of the lung and also in serous carcinomas. So whenever the differential includes these two entities, CK56 is not useful. D2,4-D is another marker. It's strongly expressed in endothelial cells of the lymphatics. However, usually it can also be expressed in mesothelial cells. The pattern of staining is membranous, and this is the stain that helps for diagnosis of sarcomatoid mesotheliomas, because sarcomatoid mesotheliomas may lose all three markers, and this is the only marker that can be positive in sarcomatoid form of mesothelioma. Calretinine is positive in 30% of the cases, so these two may help in diagnosis of sarcomatoid types of mesothelioma. This table is from the WHO book of 2015, and these are the positive markers that we use for diagnosis of mesothelioma. Presence of two of these markers is not enough to make the diagnosis of mesothelioma. We need two negative markers to make the diagnosis. And these negative markers are depend on the tumor that we consider in the differential. So if the tumor, for example, in our differential is adenocarcinoma, we can use any of these markers. In our lab, we have MOC31, BER, EB4, CEA. We can use any of these markers to make the diagnosis of mesothelioma with presence of two positive and two negative markers. If the tumor in our differential is lung, we can use TTF1 and napsin and other organ-specific markers, for example, for breast, ER, PR, hemoglobin or GCDFB, or for example, for renal, PAX8, PAX2, or RCC can be helpful in our differentials. With immunohistochemical stains, we can differentiate adenocarcinomas from mesothelial tumors, and we can confirm the mesothelial nature of our neoplasm. But the problem of differentiating between benign versus malignant processes still is an issue, and in recent years, a variety of immunohistochemical stains have been introduced to help to differentiate between benign versus malignant mesothelial proliferations. And these stains include EMA, P53, GLUT1, and IMP3 for malignant mesotheliomas, and desmin expressed in benign mesothelial proliferations. This picture shows malignant mesothelioma with expression of GLUT1. However, benign and reactive mesothelial cell proliferations are negative for GLUT1. Here are the red blood cells that can express GLUT1. However, different studies shows that although these markers can be positive in malignant mesothelioma, they are not specific enough to make a diagnosis for a tumor-like mesothelioma with this adverse prognosis. So, for example, in these studies shows the results of the immunohistochemical stains for IMP3 and GLUT1 in different studies, as shown in the diagram in the table. These two stains can be positive in malignant mesotheliomas. However, the problem with these stains is that they can also be presented in benign mesotheliomas. So the problem with these stains are that they work in a statistical way. In fact, greater proportion of malignant mesothelial tumors, including malignant processes, express these two stains. However, they can present also in benign reactions. So with this background, during the last few years, new molecular markers were introduced to be able to differentiate between benign versus malignant processes. Cytogenetic and molecular studies have shown that malignant mesotheliomas are associated with multiple chromosomal alternation, including losses and gain. Many tumor genes have been described in pathogenesis of malignant mesotheliomas. This slide is from Dr. Rasila's research project and listing the genes that are involved in pathogenesis of malignant mesothelioma in order of frequency. These four, including CDK and CDKN2A, CDKN2B, NF2, BAP1 are the 4 most common genes that are involved in pathogenesis of malignant mesothelioma. BAP1 stands for BRCA-associated protein 1, is a highly specific marker for differentiating between benign versus reactive processes. BAP1 is encoded by BAP1 gene, which is located on the short arm of chromosome 3. It's a tumor suppressor gene. It encodes for a deubiquitinasing enzyme. In fact, it is involved in ubiquitin protease pathway. It reverses the effects of ubiquitin and removes ubiquitin from the protein. So, in fact, BAP1 is involved in recruiting the enzymes that are involved in fixing the damages that is caused on DNA by asbestos. Loss of BAP1 as seen in more than 50% of mesotheliomas, and germline mutation in BAP1 predispose the patients to different kinds of cancers, including malignant mesothelioma, cutaneous and uval melanomas, and different kinds of carcinomas. And this has been described in BAP1 cancer syndrome, which is inherited in an autosomal dominant way. Somatic gene deletion or inactivating mutation in BAP1 with double hit inactivations result in loss of BAP1 gene, and this is seen in more than 50% of sporadic mesotheliomas. And loss of BAP1 can be detected by either immunohistochemical stains or by FISH analysis. This was a study which was performed to show the utility of BAP1 for diagnosis of benign versus malignant mesothelial proliferation, and in this study immunohistochemical stains and FISH analysis was performed on the cases, which included 12 cases of benign mesothelial tumors, 212 cases of malignant mesothelioma, and 42 cases of reactive mesothelial proliferations. 11 cases of normal mesothelium was included in the study, which was surgically removed due to non-mesothelial related processes. In this slide shows the expression of BAP1 in normal tissue. As shown in the picture, the normal mesothelial cells show nuclear positivity for BAP1. BAP1 also is expressed in normal pneumocytes, endothelial cells, fibroblasts, and inflammatory cells. It's also expressed in reactive mesothelial cells. This picture shows malignant mesothelioma with loss of nuclear expression of BAP1. So, usually in malignant mesothelioma, the cells are negative for BAP1, or in other words, is positive for BAP1 loss. This picture shows again negative staining for BAP1 with expression of BAP1 in the background inflammatory cells and fibroblasts or endothelial cells, and this can be used as a positive internal control. Also, BAP1 can be used in cytologic specimen in cell blocks. As shown in the picture, the malignant mesothelial cells are negative for BAP1. However, the background inflammatory cells express BAP1. And the results of the study showed that, in fact, in none of the normal or benign mesothelial cells, we had BAP1 loss. In fact, in all of them, we had expression of BAP1, and all of them were negative for BAP1 loss. About 66% of the malignant mesothelioma cases were positive for BAP1 loss, and from 42 cases of reactive mesothelial cells, 6 cases were positive for BAP1 loss. However, follow-up studies showed that all 6 patients developed malignant mesothelioma in the follow-up of these patients. BAP1 loss in this study was also evaluated by FISH analysis using a combination of probes specific for centromere of chromosome 3 and also BAP1 gene. labels the centromere of chromosome 3 as red, as green, and the BAP1 gene as red. So in normal mesothelial tissue, usually we have 2 green signals and 2 red signals. However, usually in malignant mesothelioma, we have homozygous deletion or heterozygous deletion of BAP1. As we see here, we don't see any red signals. So this is indicative of malignant mesothelioma, and in this study, from 41 cases of malignant mesothelioma, 41 cases showed loss of BAP1 gene by FISH, and none of the reactive mesothelial cells were positive for BAP1 loss. P16 is another genetic molecular marker that is used for differentiating between malignant versus benign mesothelial proliferations. As a reminder, P16 is a cyclin-dependent kinase inhibitor. It inhibits the phosphorylation of RB. So in the hypophosphorylated form, RB is active, binds the transcription factors, and blocks the progression of cell cycle. However, phosphorylation of RB results in inactivation of RB and releases the transcription factors, so the cell cycle progresses from G1 to S. So P16, loss of P16 is associated with the loss of control in the cell cycle and result in cell proliferation and tumorigenesis, which has been shown to be one of the markers for for diagnosis of malignant mesothelioma. Again, this is a similar study. The gene for P16 is located on the short arm of chromosome 9, and using probes for the centromere of chromosome 9 and P16 gene can localize the genes as 2 green signals and 2 red signals for benign or reactive mesothelial cells, and homozygous deletion of P16 can be one of the indicative of indicative of malignant mesotheliomas. And in this study, in this article, they listed the studies which performed on P16 loss by FISH, and as shown in the picture, from 220 cases of benign reaction, none of them expressed P16 loss. However, the sensitivity of P16 loss were between 33 to 100 in different studies, with an average sensitivity of 67%. So they concluded that P16 is a specific marker for diagnosis of malignant mesothelioma with specificity of around 100%, and in fact can support the BAP1 immunohistochemical stains for diagnosis of malignant mesothelioma. The advantage of P16 is that it can also has prognostic significance. Loss of P16 is associated with more aggressive course in malignant mesotheliomas. The disadvantage is that it is only done by FISH, and the immunohistochemical stains is not reliable for diagnosis of P16 loss. I wrap up my talk with my last slide, which is a study which was published last month. As I mentioned before, the diagnostic use of cytology for diagnosis of malignant mesothelioma is controversial, and some institutions are not comfortable to making this diagnosis on cytology specimens. However, in this study, they use BAP1 and FISH both on cytology specimens to show the utility of these two stains in effusion cytologies. And I'm not going to go over the details of this study. However, they suggested a nice approach, logarithmic approach for effusion cytology specimen. And they recommended that after confirmation of the mesothelial phenotype of the tumor in differentials, the next step is to run BAP1 immunohistochemical stains. If it was positive for BAP1 loss, the diagnosis of malignant mesothelioma is established. However, if it was not positive for BAP1 loss, the next step is to run P16 FISH, and if P16 deletion was detected by FISH, again the diagnosis of mesothelioma is confirmed, and if it was not detected, still the diagnosis is not excluded, and the patients need to be followed or go under further biopsies. So in summary, today we review the WHO classification of malignant mesothelioma and discuss different subtypes and patterns, and also we discuss the immunohistochemical features of malignant mesothelioma and review the new markers for diagnosis of malignant mesotheliomas. These are my references, and I would like to thank to Dr. Rasila for his expert opinion and also reviewing my slides, and also Dr. Lilemo from Abbott Northwestern Hospital, who gave the case to me to review. And also thank you for your attention, and I will be happy to answer any question.
Shifteh, that was an outstanding review. Thank you very much. You mentioned early on in your talk that the incidence of malignant mesothelioma is declining in the U.S. and increasing in other parts of the world. It's easy to understand why it's declining in the U.S. because we're doing so much to educate the populace about asbestos exposure. Why is it increasing in the rest of the world?
Because in the rest of the world, the restrictions are not to restrict, and the governments are not willing to, control the asbestos usage. So in different parts of the world, they are still using asbestos.
So it's an increase in asbestos?
Yes, and I had a slide, but I didn't put that in some parts of the world, for example, Russia, China, India, they are still using asbestos a lot in different industries.
Okay.
How much of a role is there for radiographic pathologic correlation? For instance, how often does a benign mesothelial proliferation present with a lung that's totally encased on a CT scan?
Usually, the CT scan is very reliable on diagnosis of mesotheliomas, and sometimes, for example, in suspicious cases that we are between benign reactive processes versus mesothelioma, imaging findings are very helpful. So usually we correlate our diagnosis with radiologic or laparoscopic findings, and usually the benign reaction do not show this encasing or this thickening of the of pleura that usually is seen in imaging findings in CT. So it's very much correlated.
I have two questions. First, a couple of things that you just mentioned briefly in passing. The first is you mentioned area night, and a few years ago there was a lot of concern about that because it's much more prevalent than asbestos. It's just out in the environment in various parts of the world, in Turkey and Western United States. Is there any new statistical data on area night exposure? Supposedly it's more dangerous than asbestos, than even so is there any data on that?
Data about usage of asbestos in different parts of the world?
No, I mean exposure to area night as a risk factor for mesothelioma.
Oh yes, data, I didn't arrive at the data, but the only thing that I know that is in Turkey they are using this chemical, so it's very common in Turkey, but I don't have any data on it. I just read about it.
The initial indication was that this was actually more dangerous than even the dangerous forms of asbestos, and there was a public health concern because this is something that's just floating around in the environment, just on the ground. The second question is about something that's a little bit more difficult to deal with, which is this SVahidi association. So About 20-some years ago, there were a number of publications, Jan Butel and Mike Carboni, about SVahidi playing a role in the pathogenesis of malignant mesothelioma, and I think that was largely debunked or largely proven incorrect. So did you come across anything on the status of that story?
Something that I read about it is that in animals it's associated with malignant mesothelioma, but it's not confirmed in humans. So the role is not confirmed in human, but in animals it has been confirmed.
So just want to add a few things that are more practical. So related to BAP1, basically from the talk, excellent presentation. I mean, you covered very well everything. And you presented them very clearly. Thank you. So BAP1 is a problem because it is useful only when it is lost. I mean, when there is a mutation. But only, depending on the study, only about 30 to 60% of malignant mesotheliomas will have a mutated BAP1. Therefore, if it is all positive, you cannot differentiate it from reactive mesothelial proliferation. So it has to be absent to be useful. And that is only a minority of the cases. The other aspect is for immunohistochemistry. You have a very nice table there. But many of the antibodies that pathologists continue to use actually for diagnosing malignant mesothelioma, they are not useful. They use, for example, MOG31, P4 to differentiate it from adenocarcinomas. They're unuseful because both of them, they can be present positive in malignant mesotheliomas up to about 30% of the cases. So for practical standpoint, it's only a combination of 5 antibodies that I would personally recommend, and that is a general pancytokeratin, which will be positive in both adenocarcinoma and malignant mesothelioma. But that gives you information related to the infiltration into the fat and the pattern of growth. And 2 specific antibodies for malignant mesothelioma, which are W31 and carletinine, and 2 antibodies that are specific for adenocarcinoma and absent in the vast majority, well, I would say in all cases of malignant mesothelioma. And those are CEA, carcinoembryonic antigen. That's very, very useful. And the other one, we don't have it in-house, and actually it's used only in a few institutions. It's Claudin-4, which is also positive only in adenocarcinomas. But if we use only cytokeratin with WT1, carletinine, and CEA, it's enough for that, with the proper recognition of the pattern. Now, related to the patterns, my recommendation is never use terms like signet ring cell, although they may look like signet ring, because that is actually the microcystic pattern, or adenomatoid, as other people are calling. Signet ring, if you introduce that for description of the pattern of growth, makes a confusion with adenocarcinoma. So signet ring cell is a characteristic for adenocarcinoma, not for malignant mesothelioma. Because when the cells appear microcystic, it is not because they secrete mucin, they never do that. It's because they accumulate hyaluronic acid, and actually if you go to high power and you look in the cytoplasm, you'll see the blue precipitate, which is very delicate, is very fine, but you will see it there, and that is all hyaluronic acid precipitate, is not mucin. So those are just a few aspects. Thank you for the
Thank you.
Yeah, I'll just mention a couple things that were not the emphasis of your talk at all. For me, doing GYN pathology, the peritoneal mesothelial proliferations can be really challenging to distinguish benign versus malignant. You mentioned the multicystic, so-called multicystic benign mesothelioma, which is really, I think, not uncommon, and some people think it's kind of just an amalgamation of a bunch of adhesions in patients who have had prior surgeries or who had endometriosis. So we see that not uncommonly in GYN pathology. It can be difficult also. And also just a lot of adhesive disease can result in a benign kind of mesothelial proliferation that can be hard to distinguish from a malignant one. And it's interesting, I've never used the back one, and I know it has its limitations, but it may be useful in cases in the future. And the other thing is that you mentioned it as well, just to remind people that kind of papillary mesotheliomas in the peritoneal cavity can look exactly like low-grade serous tumors, especially serous borderline tumors in the ovary. It's not a common tumor, the papillary mesothelioma, but when it's present, it's very easy to misdiagnose it as a serous borderline tumor. They have a very similar pattern of spread, and they look very similar to the microscope.
The well-differentiated papillary mesothelioma of the peritoneal actually still remains controversial because in terms of evolution, it is actually considered to be mostly benign. Those women, their survival, I mean, is really long, and many, quite a few cases are actually more than 10 years. So it is totally different than the malignant mesothelioma in the lung, or the typical malignant mesothelioma of the peritoneum that is related to asbestos or iron. So that is still a controversial thing, but is yes encountered from time to time. It is very difficult to differentiate from cells.
And there just aren't that many people that are expert at it. Like people they don't come up that often, and most of the people who are experts in mesothelioma are really a lot of mesothelioma experts, and it's hard to find people who want to deal with peritoneal mesothelioma.